Welcome back, everyone. Did everyone get their fair share of vitamin D over lunch? It's my great pleasure to welcome John Brownstein to open our afternoon here at 416. John, as is written up here, is the Chief Innovation Officer at Boston Children's Hospital and also an entrepreneur. What that doesn't say, though, is how deeply he cares about the world's data that we are producing for ourselves and by ourselves. And in fact, that is the premise for the session of this afternoon, is how can we make the most use of those data. I've been particularly inspired by prior talks that I've seen of John's, and I thought it would be really great to have him come to this type of a meeting where we could really talk across different communities and contexts to think about how we can make better use of all the data that all of us people out there are creating. In particular, his analysis of Facebook selfie data to really look at obesity distribution. These kinds of information that are just simply not available to us in our classic traditional medical contexts. Similarly, using the Uber app to deliver flu vaccines. These are the ways in which we can actually help humanity by using humanity's data itself. So with all of that, it's really my great pleasure to welcome John.
Great. It's fantastic to be here and talk to you a bit about some of the work that we've been involved in, probably now over a decade, in thinking about how, as Melissa was saying, how the new types of data that we're generating in the course of our lives can actually contribute to understanding our own health, and that in an integrated view can actually help us understand the health of populations. And so I usually like to start with an analogy to the weather. If we were in Boston right now, the marathon is taking place, and it's in the 40s, maybe 50s now. And we have the ability to open up an app and look at weather.com and easily see what the temperature is, where it might be heading over the coming days. And we all know this is because of the availability of information, for instance, from NOAA, available via API. Wonderful that this has been available and has led to a whole productive field of forecasting. But in my field, in public health, we know that all of these elements are missing. So the concept of data that is available out there, an API to that information is not available. And then, of course, the ability for apps and other tools to be able to forecast disease in populations also doesn't exist. So essentially, we're missing all of the components that you would expect as far as, when we compare to other types of fields where this information is available. And the reason, there are many reasons why these components aren't available, but a big part of it is around data and the movement of information across verticals. So someone gets sick in a population, your data moves to healthcare providers, EMRs, there's laboratory information, data flows up to ministries of health and world bodies like the WHO. But we know that then the information doesn't flow back to the other stakeholders, and every single one of those steps can take days or weeks. So by the time that we know something is happening in a population, it's been months. And so the ability for us to have the consumer view of public health is basically impossible. And that's really why we've been focusing our efforts in areas and data that is sort of beyond the sort of walls of this hierarchical information flow, data that's available multi-directionally and doesn't have necessarily stakeholders that are preventing it from flowing from body to body. And that's really important when we think about emerging diseases, especially SARS, Ebola, where not knowing who the stakeholders are, it's better to err on the point of transparency and having everyone have access to the same information simultaneously. So when we think about digital data, we think about, of course, EMRs are digital, but we think about the data that rests outside of those traditional channels. So information from blogs and chat rooms and social media sites, participatory data from the individual. And what I'll talk about over the course of this session is really about how we're taking that information and attempting to organize it. So figuring out new taxonomies and ways of interpreting that information to make it relevant for population health. And from that perspective, taking all that information, filtering it, and then turning it into data that can be used for surveillance. And initially we've used this information for understanding emerging infectious diseases, but we've now, of course, expanded this into many other domains, which I'll explain to you in a fairly rapid clip. What this information also provides is an ability to understand disease and outcomes in places with limited public health infrastructure, in places where there might be limited transparency of information flow. And that's really exciting if we want to take a much broader view of population health. And this is a field that's been emerging over, as I said, about 10, 15 years now. There are many systems and efforts that have gone into thinking about how to tap into the wisdom of the crowds around emerging disease and public health surveillance. And ultimately, it's really changing our view of how diseases emerge in populations. So this is just a visualization of the emergence of Zika, which we've been tracking since 2014. Without the ability to integrate many different types of data streams, both informal and formal, you can come up with a picture of how essentially this virus has taken a hold across South America into Central America as well. And this information is based off a system that we developed called HealthMap, which is a global, open, public health surveillance system that is all about organizing the world's content about disease. And I'll sort of explain how a system goes about doing this, because these types of tools can be oriented towards many other types of outcomes. So our system is essentially a crawler. We're taking information sources like news and chat rooms and blogs, hundreds of thousands of sites that we're mining every hour across 15 different languages, and essentially providing a view of disease events that are taking place globally. And we use NLP, like many people in this room think about text processing. We spend a lot of time thinking about how to take free text. And what's different maybe from some of the texts that you think about in terms of scientific literature, we think about internet vernacular and how to take ways in which news reports are spoken about, how social media comes across. And we tend to take that information and attempt to match it to disease patterns, locations, species, case counts that might come from these articles. This is maybe an example of a text from a news article where essentially we're identifying diseases in articles and then doing classifications within that text content. And then using machine learning tools to basically essentially categorize this content across various types of articles. Our big interest is understanding disease events that are taking place and unfolding in real time. So we have to take that information and filter it out from other types of articles that may not be relevant to a real-time continuous surveillance system. And then from there, we filter out the noise and generate about 3,000 new alerts per day. So if you think about that in terms of disease events, WHO puts at about a few hundred outbreak events per year. So there's definitely an information challenge where we're identifying many more events taking place. It's really exciting because it's filling out the world in terms of understanding what's actually happening and providing a view that we didn't have before. But it's also a validation issue in terms of how do you actually feed this information to public health and get some validation of that information in return, which I'll talk about in a little bit. And then from that perspective, we feed that to an interactive interface at healthmap.org, and essentially are providing this living, breathing map of disease. And we're one of many groups that think about this, but when I spoke about the weather.com for disease, this is essentially a first step towards that, where someone can identify within their location, might care about what's happening around disease outbreaks just as much as they might want to look at what's happening with the weather. But at the same time, this information can then feed into many different organizations, WHO, CDC, who then can actually use this information for real-time decision-making about outbreak response. So I'll give you a couple examples here. H1N1, I think we remember there's been many important outbreaks since H1N1 swine flu. But this was actually one of the first examples of how these informal sources, how news and social media were actually providing a light on the situation before official public health surveillance systems. So the first reports about swine flu actually came out of local news and social media talking about a mysterious illness in Veracruz, Mexico. And that was the first information weeks before any official reporting came out from CDC or Ministry of Health in Mexico. And I think more importantly, this actually illustrated the fact that you could organize content from official sources with informal sources and actually in real time follow the movement of a virus in real time with the emergence of all these different types of data streams if you could organize and filter them properly and curate them quite heavily. If you fast forward then many years ahead to H7N9, which is a new emerging flu virus in China, we're dealing with a very different information stream. So of course, many more social media sites are now online. We have, for instance, in this case, Weibo, which is providing vast amounts of information about disease events that we're now having to filter and utilize for the purpose of understanding diseases. But once again, it's much more of a filtering challenge than actually looking for any particular article. What's amazing now is that you're seeing, in China, in comparison to, for instance, SARS, over 10 years ago now, where you had very little information coming through, now you have people taking photos of EMRs and posting them to the social media site. So very different information streams that are coming out of these regions. We couldn't talk about digital surveillance without talking about Google flu trends. And for better or for worse, this has been a sort of a controversial system, and the idea of using search query data as a tool to understand what's happening in a population. It had challenges in that these systems weren't being tuned properly and refitted every season. And of course, people's search patterns change, the ways in which people use Google change. And so these systems tended to overestimate the impact of flu outbreaks. But they did point us to the fact that with the proper methods, these type of data streams could be incredibly useful. And it's not just Google data. For instance, we could use data from Baidu, the Chinese search engine, to basically understand influenza in China. Epidemics that are taking place in populations. Even OpenTable, not that they were that open to sharing the data with us, but we figured out a way to scrape OpenTable and essentially figure out any time that someone would cancel a reservation, and we would hit their sites every hour, and essentially came up with an indicator of table availability in cities. And so we saw that increased availability in cities actually mirrored influenza epidemics as well. So it doesn't have to be Google search data. And in places where, of course, there's not a lot of social media, you can also turn to satellite data. So this is an example of a project that we've been involved in where we use a real-time this in real time across Central and South America, where many hospital parking lots are actually open air. So you can actually see how busy a particular parking lot is in a particular hospital. And in aggregate, you can actually look at this across the continent and then see how busy particular healthcare systems are and think about the level of social disruption. In the case, of course, in the middle of a flu outbreak, you will have a lot of people coming into the hospital, and in this case, we get incredibly busy parking lots. So once again, you can build a surveillance stream without actually having to tap into the systems of the hospitals themselves. And then from there, of course, the big part is around forecasting. How do you take the information and not just nowcast, okay, with Google or Twitter, whatever data source that we're tapping into, we can get a good estimate of what's happening now, but how do we build models, temporal models, to figure out what's going to happen weeks or months ahead? And this is really what we're doing now with building the new Google Flu Trends actually shut down. We took over with access to the Google Search API, but now instead of just showing Google data, we integrate with electronic medical record data, participatory data, data from CDC to make a much more robust surveillance system. So this is all well and good for the US and Europe where we have this kind of data, but it becomes much more challenging when we're looking at the emergence of Ebola in a population. You can imagine that this was actually a real data challenge in terms of the actual numbers of reports that were coming from the field. In fact, though, there was enough for us to basically look at what was happening across news sites, from NGOs, and then some level of participatory surveillance, which from that integration allowed us to essentially see what was happening weeks ahead, but also provide a real-time picture to public health agencies of what was taking place. But more importantly than sort of understanding what was happening was building risk assessment. So a lot of our work in this case was not just about looking at surveillance data in a bubble, but integrating that with other types of data streams. So for instance, transportation networks, where we wanted to understand where we might see the risk of importation of Ebola via flight networks. So we integrated data from IATA. From there, we can actually look at the integration of other types of data streams like landscape, climate, and from that perspective, we want to see where we might see other introductions, other emergence events of Ebola. And from the data we had, we can actually build much more robust models, both spatially, but also temporally. So a big part of what we were doing as well was to understand how to take the data we were collecting, not just nowcast how many cases, but under various scenarios, how many cases we would expect based on different types of control scenarios. And then finally, looking at satellite data. And sorry, I'm getting a little stuck here. Not sure what's happening here. Okay, I'll just skip over. Okay. So one of the big sort of elements of what we're working on is about integrating this data. So it's not just about one data stream, for instance, news or social media. This is about integrating information about occurrence data, landscape, climate, and historical literature. So one of the big exciting aspects of what we do is take, for instance, PubMed searches of occurrence of disease events collecting. And this is big in terms of understanding where we might see emerging trends of disease. So, for instance, working with CDC, they have their endemic displays of vector-borne diseases like dengue. We can integrate data that we're collecting from these new types of data streams to provide information on where we might see a leading indicator of emergence of new diseases like dengue. And from that perspective, integrating historical literature information with these new types of data streams can actually provide a much more robust view of where we might see future outbreaks and actually the overall burden of disease for this very important vector-borne disease. So a lot of what I've spoken about so far is really about thinking about how to take information that's already out there and existing. But of course, one of the big aspects of what we do in public health is really about messaging and engaging people in better public health activity. And so we've been thinking about crowdsourcing efforts. We've done a number of these types of projects over time. This is one of them called Flu Near You, which actually has over 100,000 people in the system and essentially provide, sorry, I'm losing it. Okay, one second. Oh no. Not sure what's going on here. Sorry, give me 1 second. Yeah. I don't know, maybe this is a Mac issue. 1 second, I'll be right there.
This is your moment to tweet something interesting.
Yeah, no, don't. No, don't, please.
No, I meant about your talk, not
Okay. Okay, 1 second. Just need to find out where I was. All right. Good. All right. Good. Hopefully that was the last technical disturbance. Okay, so 100,000 people in the system. What? All right. F9? There's no F9. There's some Mac. All right. We're good? I'm going to stay away from the cords here. Okay, so what I was saying is, in aggregate, the information from the crowd can actually provide us a view of what's happening with influenza, for instance, in a population. So each week, people put in their symptoms of how they're feeling, how their members of the family are feeling, and from that, in aggregate, we have this incredible view of influenza, which is much cheaper to run than a current CDC system that does something similar, and provides us very detailed information about demographics, about vaccination status, and so in real time, we have essentially a participatory surveillance system that gives us new indications of influenza outbreaks in populations that we couldn't have through sort of more traditional data streams. It's still a challenge to basically engage people in these kind of tools, so we're thinking about new ways of identifying outbreaks in populations, but still giving more information to the crowd. So, for instance, we developed a fever calculator called Thermia, where essentially parents or adults that have a fever can actually find out what it means to have a temperature and actually get recommendations, standardized guidelines from Boston Children's Hospital. And so essentially what we're doing is now providing feedback and information to the population, but on the back end collecting data about symptoms and location that is feeding essentially our surveillance systems. We're now thinking about how you take, for instance, as one example, a guideline that we've now automated from children's and now disseminating through all sorts of different channels. So one example is actually an integration that we're doing in the coming weeks with a smart thermometer called Thermo. So essentially the idea is very simple, where you take a temperature, everybody has a thermometer, they take a temperature, what does that temperature mean? Well, essentially it connects to an app that you have on the phone and then throws you into a decision support tool and gives you information about what the temperature means, what you should do, and essentially dosing instructions, especially in the pediatric population. And this isn't necessarily the only device we're connecting to. There's a whole range of smart devices that are now on the market that are providing continuous temperature sensing. One is called iThermometer, and this might horrify some people in the room that people are using this to provide every 4-second reading of their kid's temperature with connection to an iPhone or Android app. Gives you an alert to your phone as soon as your kid's temperature spikes, and you can run into their room when you find that. So there's mixed reasons to do this. Key aspect of what we're doing. Something that we're really excited about is something we launched actually just last week. I don't know how many people have the Amazon Alexa device in their home. If you do, now actually it has pediatric content in it that we've now put in. Essentially now a parent has a question about a symptom that their child is experiencing, Alexa will now provide you that information about that symptom and then dosing instructions of what to do. So all sorts of new technologies where the content that we're providing can feed information, but then on the back end we're collecting huge amounts of data on population health. And then one last aspect about fever, this is actually our research kit app that we launched also 2 weeks ago called Fever Prints. We recognize in trying to build tools around fever that we don't actually even understand what fever means, and the guidelines around fever and what is normal in terms of temperature were based on small amounts of data, guidelines built decades ago. So what better way to refine and redefine guidelines in temperature by using the new iOS research kit, where we can connect the app to various devices, thermometers, or self-reporting temperature, and actually start to redefine what baseline temperature means in populations. Okay, so I've spoken a little bit about the infectious disease realm, but there's a lot sort of more that can come from the data that we're collecting. And this is, over the last few years, we've defined a concept called the digital phenotype. So this is an idea of what you say and do online and what your devices tell you about you can actually are a direct reflection of your health. So your online behavior is somewhat related to your health status. And this is something that we've been working on to think about the various examples in which the data that we're generating, whether we're querying online or talking about the awful technical issues in my presentation on Twitter, how that information might say something about you more than it says something about me in terms of your own sentiments. We'll talk about that. So, many different examples. I'll touch on foodborne illness in a minute, chronic disease and how people refer to diseases they experience, drug safety issues. I'll touch on that in a moment as well. Drug abuse and diversion. So what's interesting is many behaviors or outcomes are ones that people to their physician, so an information or report in a survey. So many types of data that we would never get otherwise. And then patient experience, which I'll talk a little bit about as well in terms of how we're trying to redefine how we estimate quality of care. Okay, so first example, this was actually an early example where we wanted to see how people refer to abortions online and actually search for them on Google. And so what's really interesting is that places that tend to be much more restrictive on abortion actually tend to have the highest searches. And this probably makes a lot of sense because places where there's not a lot of access, people turn to Google to find where they might receive access. And it's not a mistake that the red dots and the blue dots, red state, blue state, are sort of there and distinguished quite significantly because, of course, in the states with more restriction tend to have the highest searches. And that kind of pattern actually extends globally as well. Countries that tend to be much more restrictive also have the highest amount of search. Gun research, of course, that's a very hot button topic today, as you know, but of course we know that there's also very limited amounts of data and surveillance information that come at the national scale. And so we're working to understand new ways of getting indicators of gun sales, of gun violence through various different social media sites. So as you can imagine, searches for ammo are really correlated with, for instance, gun purchases or background checks. As you can imagine, people don't usually search on ammo if they're not looking for ammo, or that's not a confusing term. Usually you're looking for it. You're not just looking for general news about ammo. So that's a good search term. And in fact, from there, we can start to build in surveillance systems, not just on searches for ammo, but looking at Twitter data where people refer to gunshots and gun violence and start to organize that information to provide a real-time view on what's happening at the community level through organizing this information and actually understanding what the community conversation is about these various topics, whether they're policy-related or violence-related. There's a combination of those types of topics. So we can do topic and sentiment analysis. Obesity research. I'm not sure how many people are on Facebook here, but what we found is that what people like on Facebook tends to be a reflection of their health. So if you like running and cycling, that tends to be potentially correlated with your the real world health of you as an individual. And we started looking at that in combination in communities. So communities that tend to like more physical activity tended to be healthier and have lower BMI. Communities that tended to talk about movies or watching television, more sedentary behavior, tended to be less healthy communities. So, of course, you can imagine that, as we think about the digital phenotype, the information that we're producing online could be valuable information, for instance, in the course of your care. This was the project that Melissa was referring to, where we thought, okay, well, we were being a little bit cheeky, but we thought, okay, well, if, Facebook likes are useful, what about selfies? And so we turned to Instagram to start looking at selfies and if we could estimate BMI from people's photos. And there actually is pretty good literature to support BMI and selfies, but this is in a very controlled setting. We try to do this with Instagram data, which does not have very standard ways of doing selfies, as you can imagine. And so the results weren't great. This is not one of our best moments in research, but it was pretty scattered, and mostly because people tend to do duck face and other types of things on selfies and actually don't produce necessarily the best estimate of themselves. It's the best reflection. It's not necessarily an honest reflection necessarily all the time. Okay, so mental health. You can imagine that there are ways in which people talk and search for things online. And in fact, for instance, when we think about psychological distress and unemployment as an example, you can see there's some really striking relationship between increases in mental health related searches and, for instance, unemployment. Once again, this is aggregate level data, but you can once again think about how you can look at indicators at the individual level. Actually, Microsoft has done some fantastic work at looking at longitudinal search data to look at potentially predictions of mental health related issues based on just simply your search data. Okay, foodborne illness. This is one of my favorite examples. A conference like this, but actually taking place a little bit north of here in Victoria, BC. All of a sudden, someone tweets out, motion that nobody else on this bus puke. So gala event, someone gets sick. And all of a sudden, what's amazing is that this becomes this crowdsourced view of a foodborne outbreak that's taking place right in front, in real time. I don't know how much people want to see these kinds of tweets. Zombie horror film as an example, and actually someone taking a photo of the ambulance coming to the hotel to pick people up. So, of course, this is not a massive public health problem. This was a very small outbreak, but it tells you that in some ways, this outbreak unfolded in real time, while maybe a public health agency might have only found out about it weeks or months later. And, okay, this is when things got back to normal after 36 hours. And what we know is that there's so much being reported about foodborne illness and poisonings online that far outweigh what's being reported to public health agencies. And so we have this view of the world that's quite different than what's actually, what is being officially reported, either because they're not identified or they're not coming from local public health departments and filtered up to the CDC. And so we're working, for instance, with Yelp to actually utilize Yelp as a surveillance source. So I'm not sure if people knew this, but 10% of all Yelp reviews are food poisoning related. And so we can use natural language processing to identify these events. I'm not going to tell you which restaurant this is, but basically to look at the ingredients that are implicated in foodborne poisoning. And actually, we've done validation against CDC data, and the correlations are pretty amazing in terms of what ingredients tend to be most related to people's poisoning. But then you can even go further because on Twitter, there's a lot more data about food poisoning, actually close to 1 billion tweets over 4 years talking about food poisoning. You can imagine, I'm sure nobody here tweets about the diarrhea, but there are a lot of people that are doing it. And actually, we were lucky enough, somehow we put a proposal to Twitter to get that diarrhea data, and they were happy to give it to us. And so here you'll just get some good examples of things that people tweet about. A lot of great goodies. If you guys are bored later, I can send you some. We have lots of tweets going on here. So what's exciting is that now public health agencies really that have a quite of a big disconnect between what they do and the community can actually create a better connection with the public. We say putting the public back in. Well, so we're working with local public health departments to create dashboards. We're starting with Foodborne because it's an easy place to start, but giving them access to the data, the stream of information coming from their community so that they can begin to interact. So why can a public health department react the same way that, the great Twitter feed of Taco Bell responds to you when you complain about Taco Bell? Public health agencies should be able to do the same thing. So we're actually creating tools for them to create automated responses back to individuals and actually engage with them in ways that they haven't engaged with them before. But even more exciting is that we can then create customized forms for those people to give much more information about the restaurant, the site, what happened, and then from there we can connect the sort of passive surveillance to the more active surveillance. And I think that's where there's some really exciting opportunities. Okay, sleep. Once again, you may or may not realize this, but a lot of people are complaining about sleep issues online. We collected about 1.3 million tweets related to sleep over a two-year period. This is just a snapshot of keywords where people are complaining about sleep-related issues. And you can just sort of see, it's hard to tell, but this map sort of lights up based on the timing. So the blue indicates it's sort of the middle of the night where people are complaining about sleep. And we can actually look at terms longitudinally over a 24-hour period. So you can imagine certain terms like can't sleep or Ambien pop up in the middle of the night, and this is adjusted for time zone. And we can then look at individuals, and we can actually start to look at their sleep patterns by their interaction with social media. So you can actually identify an individual just by the amount that they're engaging on social networks. You can actually see that they were just not sleeping enough because the time windows between their interactions on social media are way too small. So you can begin to look at this information, and in fact, we've been working to do, for instance, case control analyses to look at, okay, the people that talk about sleep issues versus the people that don't talk about sleep issues, what are the differences? Of course, they tend to be, the ones with the sleep discussion tend to be much more active in the middle of the night. That makes sense. But they also tend to be much more negative. They tend to be much more socially isolated, less followers and connections on social media. So there's some interesting issues that play out on social media, things that we already know about that are related to sleep issues, but they actually tend to play out online in the dialogue. Okay. The other aspect and one big area of opportunity is around medication use. So you can imagine, especially around adverse events and understanding concerns about emerging products and potentially issues that were not identified in clinical trials. So huge area, if you think about side effects, huge number of side effects around products, only a small sliver of those ever get validated or verified by FDA, by pharma, just because of the data that we're producing. Many people don't even realize to be reporting these issues, or they might not even remember to report them to their physician. And so from our perspective, it's one thing to just, be a pharmaceutical company or the FDA and just wait for people to report issues, but why shouldn't we just be much more active in going to places where people are already complaining about the products that they're on? And so we've been working with the FDA to build essentially their social media mining platform, where essentially we are taking what people say across forums, patient-generated data, this is an example of Twitter, and actually turning that into regulatory translation. So identifying the drug, the outcome, and the time, the reporter, all the elements that are required for an actual adverse event report to the FDA, and connecting that back to Medra. So you can imagine that there's a huge amount of information online, and as we said, there's this concept of internet vernacular. So the ways in which people talk about their issues, the typos, the spelling variations, different ways, there's Canadian spelling in there, combined or invented words. So when we think about EMRs and the types of ways in which we analyze them, hashtags aren't part of the sort of equation. And so there's a whole new, essentially, way of interpreting the sort of the internet-generated data. And of course, implied phrases. You're not going to see never eat again or eats like a mouse in an EMR. And so from there, though, we spend a huge amount of time and have spent years building this, but essentially turning these terms into connections back to more formal taxonomies like Medra. And so from there, then we can begin to mine this information and make use of it. Beyond that, we have to actually identify whether a post is actually related to an adverse event. And so, for instance, this one. And so what we do, and this is probably very similar to activities that happen here, but this is around understanding an adverse event, look at the terms that are generally associated with an adverse event and the combinations of terms, and then from there, identify a score of the likelihood that this might be an actual adverse event. And so that's essentially how the system is processing huge amounts of data. So over the last couple of years, we've processed 77 million posts about drug-related issues, and 2.1 million of those are related to adverse events. So we call them proto-AEs, posts with resemblance to an adverse event. And to get there, we've actually manually labeled over 300,000 posts. So for a few people on the team, that's really been a very tough job. I don't know how much time people spend reading what people say, but it is challenging, but it's produced some really interesting and exciting insights. For instance, the fact is that what people say online about products generally matches up with the outcomes that people report from other types of traditional systems, like the FDA's adverse reporting system. So generally, ultimately, the relative proportions are similar, but there's some really critical differences. As you can imagine, certain types of outcomes will never be reported in social media, or not usually. People usually take some product, have a heart attack, and are tweeting it in the ambulance on the way to the emergency. That's not usually, so we will get way less severe events than what will come from the more, from the more traditional surveillance system. At the same time, though, we get actually some really interesting information about less severe events that don't come from, because you don't think to mention it to your physician or to report it. So things like rashes or just issues around adherence of a product, really key issues that actually people's ability to stick with that drug over the years, but things that might not ever bubble their way through in terms of the traditional systems. So anyways, this is a whole new area of pharmacoepidemiological study where we can understand what's happening with patients. And actually, there's lots of different ways in which we can start to look at this data. So of course, adverse events are one, but maybe someone's adverse event is actually a new patient benefit. So weight loss, that could be an adverse event, or it could be a benefit, as you can imagine. Issues of product quality, these are things that are a huge concern, and surveillance around them is not that great, but we can start to look at this information through these channels as well. Resale, I'll mention that in a moment, but when there's such a high sort of visibility on the costs of products, being able to understand the costs that people are enduring and the value of these products in the black market. And pricing, of course, as well. We know there's huge heterogeneity in product pricing around the country, and these data can provide some reflection of that as well. And then one area that we're really excited about, of course, is off-label use. And there's so much discussion about people using a product for not the indicated purpose, and can we start to identify signals of new opportunities around products as well. And then from there, of course, not everybody gives enough information in a tweet or a Facebook post about their experience with a product, but once again, we can start the connection between the passive surveillance and the active surveillance, where we actually start to connect someone into an active surveillance system called Medwatcher, which is basically our app that is essentially takes the Medwatch forms. I'm not sure if anybody's ever had to submit an adverse event here, but it can take up to an hour just to go through the online documentation. This streamlines it to just a couple minutes so someone can report back directly to the FDA. In terms of drug use, of course, there's adverse events and new benefits, but you can also start to look at what's happening in other ways in which people interact with products. This is just posts that come directly from Instagram. I'm sure you've never seen these in your Instagram feed, but these are things that are happening in plain sight around the resale of medications. And these are just some highlight photos just so you can see. So in fact, on one of the most popular social networking sites out there, people are taking these products and posting them for sale. This is my favorite one. But what it related to us was that there was so much interest in talking about sale of products that there might be a way to actually understand the black market value of some of these products. And so we launched, and this is actually our most popular website, amazingly enough, by far of anything we've ever done, and we never as in any way. This is called streetrx.com, and this is basically the black market indicator of basically every prescription drug, and actually some legal drugs as well, where people go on the site and they put in the price that they paid for a drug, for OxyContin, Vicodin, whatever product they want, and essentially other people come onto the site and rate whether they got a good deal or not. Before you freak out that the site exists, I'll explain while we're doing it. But anyways, the idea is essentially people are coming in, and we actually use the crowd to remove outliers that are, of course, people are just playing around with the system. But what's amazing is that you can actually start to look at the value of products on the black market. The crowd, in terms of understanding the value of products, is incredibly smart. We've done analyses of looking at the potency of a product and its value, and they are directly related to one another. And in fact, you can start to look at the value that we're collecting on StreetRx versus, for instance, what law enforcement is collecting around the data. We tend to have lower prices than what, for instance, law enforcement paid for the product, just because, of course, law enforcement's incentivized to do the bust, so they pay more. But now there's this sort of cyclical effect because law enforcement uses the website, so they are able to use the best price when they try to do a bust. And in fact, the connection, we also publish, and this is amazing in terms of just publication, we are the only think paper to have published on Silk Road data before it went down, and so we're very proud of that fact that we used Silk Road in a scientific publication. Okay, now I'll explain why we do this project. So OxyContin, for instance, of course, huge impact on public health. OxyContin had a reformulation where, for instance, if you had to crush it, you couldn't get high off the product. So we wanted to see the real world evidence for whether that was actually deterring people from abusing the product. So immediately after the introduction of the new OxyContin formulation, the price dropped dramatically. So this for us was great, and it provided good evidence to FDA and DEA and others that it was having the intended public health impact, where just the interest in the product was going down. Ultimately, though, it's not great for public health because we've just seen sort of people move over to heroin. So it's actually worse, probably, in the end. But this system is providing the evidence for what essentially is emerging. And we know that, of course, if OxyContin is going down, then there's other products that are taking off. And this surveillance system is providing that sort of ultimate view on what's taking place in real time. And then, of course, we can start moving into dark web surveillance, and I don't have time to get into that, but of course, you can start to imagine there's even more interesting and crazy data that's out there that's where there's opportunities for mining and utilizing this information as well. Okay, so as I mentioned, a lot of our work is also now thinking about how to understand new metrics of quality of care. And so patient experience is such a big hot-button topic. I'm not sure how many people are following it, but of course, as we think about transformation of care to more value-based, thinking about how people value their experience in a healthcare setting is so important. The way that this is done generally is through surveys, and that is challenging because they're super expensive and they take a long time to put together. But you actually have real-world data right out there if you can start to mine it. And so these are just some examples of ways in which you can start to mine what patients are saying about their experience in healthcare settings. You can also look at the negative things that people say. There are a lot of really interesting ways in the way people talk about their healthcare. And then you can start to map that information. You can look at this by hospital. And all of a sudden now you can start to look at factors of what drive good quality care. You can do topic classification. You can imagine time, waiting, the cost, food. All these things are big factors when people think about, how well their stay was in a particular hospital. And then we can look at other things like, for instance, factors that drive overall how people feel the sentiment about a particular hospital. Profit status actually was a big factor in bed count. So large hospitals, large nonprofit hospitals tended to have much more negative opinions on social media. And then we can also look at that compared to more traditional measures. So hospital readmission, which is a big metric. So how likely are you to be readmitted to the hospital within 30 days of having left the hospital? We wanted to see whether, say, Twitter could actually be a replacement for the very expensive surveys. And what we found is that generally, the more negative people's view of a hospital was, the more likely that you would have a 30-day readmission to that hospital. So new data sources that could provide us this real-time view of care. And in fact, so like every project, we put out a website. This is crowdclinical.com, which actually now puts out hospital rankings based on social media and other sources. So essentially, it's a new way for people, and this is all in plain sight for hospitals to deal with if they want to. I don't have the Boston Children's logo. They didn't let me put it there. They didn't want to be associated, which I totally understand. But so this is an exciting new way of looking at people's reactions to quality of care. Okay, I'm sure people read about this story recently. So another way that we can start to look at social media and its impact and understanding public health interventions is, of course, around public health interventions and how people view, for instance, immunization, vaccines. Of course, there's so much misinformation and misunderstanding about vaccines, and the way to basically understand that, you can start to look at the patient and public discourse about vaccines by tapping into the conversation that's happening online. This is a project called Vaccine Centimeter, where we're actually tracking what people are saying about vaccines. So for every possible vaccine in every country, looking at what people are saying and what is emerging as sort of the next rumor, to ultimately arm public health agencies with what is bubbling up in the community about a particular vaccine and hopefully intervene. The intervening part is really challenging, and it's still unclear how the right communication process is needed to sort of counter a vaccine rumor as it's emerging. This is just to give you a sense of just proportions of different rumors for different vaccines. This is just numbers of reports of a rumor around a vaccine, and the reason the US isn't on there is about 100 times greater than any other country. So just for scale purposes, removed it. Huge amount of misinformation that's taking place, and you can start to look at this also temporally and look at the discussion, for instance, around the HPV vaccine and the negativity, for instance, around that vaccine and the impact of external factors, like, for instance, Michelle Bachmann saying something about the HPV vaccine. How does that change the conversation? Where do you see the sort of increased negativity about the vaccine? So some really interesting insights that can be gained by just looking at this kind of data. So our sort of response to the issues of vaccines is to build that engages people to know about what vaccines are right for them and to make it as easy as possible for people to essentially access vaccines. So we run a project, this was a project that we took over from Google a few years ago called Vaccine Finder, where we work with every CVS, Walgreens, Walmart to essentially get their supply information about vaccines and essentially match people with the right vaccines in their community for the lowest cost. And that's exciting, but it's still very, very challenging to get people to get immunized. There's over 70,000 locations in the country. You basically can't walk a block in most urban centers without finding a place where you can get almost any vaccine you need. It's still incredibly challenging, and of course, we know that over 60% of adults, for instance, don't get the flu shot. So this is why we went to Uber with this idea of like, well, what if it's so hard to get people to go to the vaccine, why can't we bring vaccines to people and think about an intervention in a completely different way? Amazingly enough, they agreed to put vaccines in Uber vehicles and deliver them and add a button on the Uber app called Uber Health. And we did this once in 2014 and again this past flu season, where we essentially armed across this past season 40 cities where they had nurses in Uber cars where they're delivering vaccines. So the idea of trying to change the way that we intervene and interact with the population, doing it at their home and their offices, and really changing the perception of the flu vaccine. This is, if you can read that, this is one of my favorite Twitter posts. But what's really interesting is that of course, there's issues in terms of access of the vaccine, and we're not necessarily accessing all sort of important groups. But one group is, of course, the populations that don't necessarily have access to easy access to the flu shot and tend to not make that part of their annual habit. And so it was really exciting in that we could start to change in which people's decision about getting a vaccine just by making it convenient. So many of the people, 40%, hadn't actually had a flu shot the previous year, and many of those had never gotten a flu shot in their lives. So the idea of just pure on-demand concept was actually incredibly important to the ultimate activity of getting a flu shot. So it wasn't that they were necessarily philosophically opposed to the vaccine. It was just that it was just not convenient. So we think about these things in terms of how we're going to engage in participatory research going forward. This is a big factor. And even more important than the events themselves was the scientific communication about the effort that that sort of unfolded, and in terms of the number of impressions and positive press about flu shots. And I don't, so I was I guess my own thing is Ashton Kutcher tweeting about your research is probably more effective than applause, no knock to applause. So anyways, I'll take Ash. Yeah, so it got a lot of retweets, so just say that. Okay, so I'll leave it there. Of course, there's a lot of different types of projects that I've spoken about, huge amounts of benefits, and the idea that what we're tapping into is super unique, unfiltered discussion about health outcomes that often you wouldn't be able to get from other sources. And I think that's why there's such a bright and exciting future about these new types of data streams. So absolutely super exciting. And I'm sure in the discussion in the panel, there'll be a lot of discussion about the ethics and consent and should we be using this data, should we not? Do people understand the privacy controls? Absolutely, lots about how this data should be used. And so I think that's probably worth a discussion. There's huge amounts of opportunity. So there's limited scientific progress right now in the methodology and how this data integrates with other sources, but it also means that there's huge opportunities in sort of a whole new research field that's emerging in essentially utilizing these sources to understand population health. So I will leave it there. Thank the funders of this work and the team, very big team at Children's Hospital that's involved in all this. I can't really take too much credit for it. Lots of great people involved in doing this, and open it up to questions. Thank you very much. Is there time? I can't tell. Okay. I guess we have time for a few questions before the panel. Yeah. Yeah. Okay. Well, I'm not sure I would say brightest because I was feeling my phone buzzing. Oh yeah, I'll repeat it. I think it was a very good question around the generalizability of the findings, given that it's very self-selected population. That I agree with. The comment about the brightest, so the comment that this is not generally the brightest, I actually felt my phone buzzing. I assume there were some tweets, so I think there's a pretty smart group here. But ultimately, yes, there's definitely, it's not a representative sample, so we're very careful to think about this data. So for instance, around the work with the FDA, we're not making an assertion that this is the rate of this adverse event in the population. This is a signal to then look at more traditional data sources or to perform a more traditional analysis. We see this as sort of a leading indicator potentially of a problem. So the same with outbreaks. We're not going to make an assessment of the rate of influenza in a population. But if we see this rising, and maybe this isn't a specific population, that population can still be a sentinel of a broader issue in the population. That's really the way that we've been treating it. With Facebook data, there's more opportunity to do something more representative because, about 90% of the US population has a Facebook account. So there's an opportunity there to do something that's much more population representative. But once again, we're very careful in how we extrapolate our findings.
Yeah, so how do you feel about the reproducibility of your work? It seems like you have some data sources that are kind of pseudo-publicly available, like Twitter, but others ones where you have probably particular agreements to get access to that data. So can you comment on that?
Yeah, so actually all the data that I would say I presented is publicly available information. It's public data. I would say I'm trying to think of any example of data that wasn't open and available. Facebook data, actually, so I'll just say the issue of Facebook is we use public data on Facebook. We use the public API of Facebook. Facebook, and this is actually a challenge of Facebook, they actually shut down their public API, so it's actually stopped all research for us, actually, on using Facebook, unfortunately. That was a huge opportunity, and so now it's gone. So it's gone for us. So we don't have any special access. We'd love it, but we just don't. So generally everything I presented, I'm trying to think of something that I didn't present, but generally everything I showed today was open and public data that we just made use of. And even the Google data, the search data, generally that's all available on Google Trends website. We have an easier access to it via the search API, but you can get that exact same data on the Google Trends website as well.
Am I next? Okay. I'm here.
Okay, hey.
So I realize you're looking at data at a macro level, but obviously from the example, you are looking at individual micro-level messages. And I'm interested in what policy discussions you had internally when at the micro level you would encounter messages that had to do with things like suicide, domestic violence, child abuse, terrorism. I'd just like to know what internal discussions that led to and policies perhaps.
Right. That's a very good question. I mean, we've generally focused on disease events that were not necessarily triggers, but of course, as we're building this gun violence site, that's actually a very good point. We are not necessarily seeing specific messages that relate to terrorism, as an example. What we would do with that information is very key. I mean, of course, if we saw that, we would report it, but our idea is that, we're looking at this stuff in aggregate. Individuals are curating, so I think that there are some, if they identify these kinds of events, they would report it up. I have never encountered actually an example where that took place, but actually that's, it's a very good concept, actually. It's something that we should look into. Yeah.
Thank you very much. On your title page, the word participatory research was explicitly mentioned.
Yeah.
In cases of these data that you use, can you consider them being actually participants in the sense that we generally use the term?
Yeah, so we had sort of two types of work that was going on, the more active surveillance and passive. So the participatory research was the work that we're doing on influenza, work on research kit, and then also our view is that there's going to be a blend between the digital exhaust, so things that people are just producing as part of their day-to-day lives, but then the engagement that might happen from researchers or policymakers, public health, from that data. And so we think there's a really exciting merger of those two data streams. So, as I said, someone talks about a problem with a medication, there's no reason why the FDA can engage with that person and start to do, whether it's public health surveillance or research, in engaging that person to recruit them into a study. So that's sort of where we think there's an opportunity, sort of blending those two types of efforts. The idea that someone is just tweeting about, some outcome, does that make them a participant? I don't think necessarily. I think that's a good question to ask. And I think it's sort of how do you take that person that was engaged at some level to talk about an outcome and bring them into being more part of the research community. Yeah.
That's the last question.
Okay, I'll be fast. How close are you, or how close have you ever come to a situation in which the data that you're collecting could have resulted in real-time action? For example, right now we're talking about, basically deferred analysis of research.
Yeah.
But if you're seeing a spike of say, people puking in hallways, like that scenario you outlined before, have you ever been in a situation where you've been close to actually being able to influence direct real-time action?
Yeah. So yeah, the real-time puke, that's a good one. We have not necessarily, because in the it's even challenging. What does public health do? I think on the adverse event side, yes. So actually, we've actually had a few examples where we've actually changed labels because of the products that the adverse events that we've identified. We've definitely started numerous more official studies on understanding whether an adverse event that we're finding through these channels is actually real, and from there actually impacting the label of that product. So I think that's one where we've had closer sort of direct impact, direct action. The issue of social media and public health and what to do, that's more challenging. I think there's still this issue of how do you connect the data to a potential action. This is what we're doing now in terms of working with cities to essentially, and actually we've started this with St. Louis, where someone talks about, for instance, an issue that they experienced in a restaurant. St. Louis will then speak back to that individual, get more data, and then we'll direct, for instance, investigations of that restaurant. So that's a direct cycle of sort of an activity on social networks and a response. Yes, great, thank you. Okay, thanks so much.